Good afternoon, everyone. Today, we are going to discuss a very important concept, that is de-prescribing in long-term care. So why de-prescribing is required in long-term care? Because long-term care means there is a possibility of polypharmacy. And now you can, if you just check these numbers, then you will understand why de-prescribing is required. So just check the two sides of Atlantic Ocean. The prevalence of polypharmacy is almost more than 40%. In Europe, in Swedish population, it was around 44%. In elderly subject, elderly means more than 65 years. And excessive polypharmacy, that means 10 or more than 10 drugs per prescription, that is almost 12% in Sweden in that same study. Whereas in USA, there was a prospective observational study conducted which suggests more than 80 years of age, which was 8.2% in 1999 to 2000, the polypharmacy prevalence becomes 15% in 2011-2012. So there is a sharp rise of 7% in overall US adults. And if we just consider the elderly population, more than 65 years of age, then it was found the polypharmacy, that means numerically more than 5 drugs per prescription, almost 40%, that means 39% of them have polypharmacy. And there is a 15% increase from 1999 to 2012. And there is another study which suggests in ambulatory elderly cancer patients, 84% of them were on more than 5 drugs, 5 or more than 5 drugs. And 43% have excessive polypharmacy, that means more than 10 or more than 10 drugs per prescriptions. So you can see the picture of polypharmacy worldwide. Now, if we just consider one systematic review and meta-analysis conducted in India, the pooled prevalence of polypharmacy is almost 50% here. And hyperpolypharmacy, that means 10 or more than 10 drugs per prescription, that is prevalence is 31%. And unfortunately but true, that potentially inappropriate medication use, almost 28% prevalence. So this is why we need to understand the concept of de-prescribing for rationalize our prescription. So first of all, we had talked about polypharmacy. We had defined it already numerically. That means concurrent use of 5 or more than 5 medications per patient. It should include the over-the-counter drugs, other complementary medications like Ayurvedic, homeopathy, Unani, different types of medicines, different types of traditional medicines. So it is not only the prescription drug, but also the non-prescription drug we need to consider. And that is why a detailed medication history is very much required to assess polypharmacy. Now coming to another important aspect, as we are talking about numbers and numbers, but numbers does not always matters. It is very important, and different experts in this subject had told we need to be more qualitative while defining polypharmacy rather than being quantitative. So appropriateness of therapy is more important while defining polypharmacy compared to just numerical counts. And that is why the potential benefits of treating patients with such certain drugs need to be outweigh the potential harms so that we can say this therapy is appropriate. And for that, the definition of potentially inappropriate medication is very important, and it is defined as per WHO as medications with ineffectiveness or high risk benefit ratio for a particular individual or group of individuals. There is another concept of polypharmacy that for one ambulatory patient suffering from one disease or to treat one disease, it should not be more than 2 medications. If it is more than 2 medications, then we can define it as polypharmacy. But here we need to understand polypharmacy does not always mean it is a bad thing. It is an irrational thing. There is need of rational polypharmacy too. So if we just go by the numbers or numerical definition, we can overdiagnose the inappropriateness of prescriptions. So rather, it is better to have our views qualitatively, because diseases like HIV, like tuberculosis, from beginning we need more than 2 medications to treat it. So there the polypharmacy is rational. So there is no harm in that. And even in some patients who require 3 anti-diabetes agents to get his or her HbA1c under 6.5 or under 7, that is a legitimate polypharmacy, rational polypharmacy. We need to promote that. So that is why while we are defining polypharmacy, while we are taking decision on de-prescribing, we need to be more and more stick to the subjective definition of polypharmacy, or rather we can say qualitative definition of polypharmacy. So as we all know, we prescriber and our patients are connected by prescription. And there is no doubt in that prescribing itself is a risky behavior. And what is our goal? Our goal is to provide the rational therapeutics by balancing between benefits and risk. In this slide, a beautiful study published in American Geriatric Society Journal, it had been shown that with polypharmacy, the inappropriate medications rise. But along with that, you can see here, the underused medications also rise. So inappropriate medication use and underuse were common in older people taking 5 or more medications, with both simultaneously present in more than 40% patients. So this is very threatening, and that is why polypharmacy does not mean only the overprescribing or inappropriate prescribing. It is sometimes that we are denying patients to get some rational drugs. So polypharmacy and under-prescribing, they had a very clear-cut relationship. And this study was published in British Journal of Clinical Pharmacology. You can find it. So this is why we need de-prescribing. it is very important to note, de-prescribing is not about denying the effective treatment to eligible patient, but it is a positive patient-centered intervention. Yes, there are inherent uncertainties. This requires shared decision-making, informed patient consent, and close monitoring of the effects while we are doing de-prescribing. But it is a positive intervention. So by definition, it is the systematic process of identifying and discontinuing drugs in instances in which existing or potential harms outweigh existing or potential benefits within the context of an individual patient's care goals. So here we again need to reorient us that we need to much becomes or much follow that POEMS, POEMS, rather than DOES. That means patient-oriented evidences, POE, patient-oriented evidences, M, that matters, rather than DOEs, that means disease-oriented evidences. So we need to be more patient-oriented and patient care goals. Our objective should be SMART, that means specific, measurable, agreed upon or achievable, realistic, and time-bound. We need to have that concept of their current level of function, life expectancy, values, and preferences. We need to respect their own preferences. Yes, within certain limits. Sorry. So this is very important, and while we are de-prescribing, the first step is diagnosing a problem. Whether there is some use of an inappropriate drug, then we need to make a therapeutic decision. That means withdrawing it with close follow-up. Because there are some drugs, if we just withdraw, there could be some side effects, adverse effects. So withdrawal effects. So we need to monitor that. Very commonly, we had very recently seen that de-prescribing is not done by any doctor, but patient himself stopped taking clonidine 100 milligram thrice daily. He was on. Now, he was presented with a TP of around 240 by 160 and admitted in hospital. So this is very unfortunate, and we need to be very cautious while taking this therapeutic decision. And after taking that therapeutic decision, we should have a close monitoring. And after this de-prescribing, this will alter the natural history, reduce the incidence of drug-related adverse events, specifically the falls. Actually, by de-prescribing, we are not only reducing the risk associated with one particular drug, but also we are reducing cumulative risk of multiple drugs because of their different types of pharmacokinetic and pharmacodynamic adverse drug interactions. So this is very important to note. And prescribing is very important to understand. It is not just a snapshot-like thing. It is a continuous process. So good prescribing continuum contains these following steps. Should contain these following steps. There should be, yes, therapy initiation, dose titration, changing or adding drugs, And finally, if required, switching or ceasing drug therapies. So whole this continuum we need to understand. And while doing or dealing with polypharmacy and deciding on de-prescribing, we need to risk evaluation. We need to do this risk evaluation of polypharmacy. There are certain criteria like Beer's criteria, stop criteria, start criteria, and also this medication appropriateness index. We can find it in internet. You can just search and you will have that calculator of medication appropriateness index. So what is the difference between those Beer's criteria, stop criteria, and start criteria, and along with this medication appropriateness index? Generally, this medication appropriateness index is depending upon the one man's own knowledge. So as I am a prescriber, these questions actually, the decision is dependent upon my knowledge, my expertise. So this is mostly personalized, and I can change my decision as per the patient's needs. So patients oriented, if we can say, this is more patient oriented, these calculators, and it is very much subjective too. Whereas the Beer's criteria, stop or start criteria, they give us an overall guideline. There is no scope for individualization. My individual expertise does not have any role on that. So all these criteria are very important. They help us to assess the risk. So reviewing the medication list of patient to find potentially inappropriate medication is a very important step. And therefore we need to have a detailed medication history. Whereas whether there is some duplication of medications, one patient is taking pantoprazole, the same patient was visiting some orthopedic physician for some reasons. He was prescribing rabeprazole. Same patient visit to another endocrinologist, and as he was giving for primary prevention aspirin, so he is prescribing a ranitidine. So this thing may happen. So we need someone who can actually have a reconciliation altogether, making all together all the prescriptions they can take, they can assess, and they can finally advise what to take. And this is actually a very important method to help out our patient to prevent different types of risk associated with polypharmacy. Whether there is some drug-drug or drug-disease adverse interactions, or patient requires some adjustment of medication dose due to some comorbid conditions like renal compromisedness or hepatic disease. And this principle of clinical pharmacology is very important specifically to address polypharmacy, and that is clinical pharmacological review, reconciliation, and feedback of drug therapy. And that help our patient to prevent different atrocities that may happen due to polypharmacy. So to have a successful de-prescribing, we need to assess the prescription from the point like no indication for a current drug, but it was prescribed. Indication for a drug, but it is not prescribed. Too much or too little of those. Adverse drug reactions, including drug allergy, drug interactions, some incompatibility, some cumulative toxicities or adverse drug reactions, adherence issues. With polypharmacy, the number of pill is increasing, so adherence will go down. There is an inversely proportional relationship. But specifically, during the transition of care, medication errors happens. And we need to be very cautious regarding that. And we need to do rational de-prescribing there. In long-term care, we need to monitor drug therapy, different adverse effects, and according to, we need to do this de-prescribing. Prompt review of freshly prescribed drugs or regimes. If some new drugs given, then we need to assess whether some adverse effects is happening to that patient or not. And obviously, in this era of precision medicine, our treatment need to be individualized. It should be based on the specific pharmacokinetic, pharmacodynamic rationale for particular drug. Whether there is some adverse impact on quality of life or not. And finally, and most importantly, this is often missed, the affordability issues, availability issues. So we need to take care of this all thing while doing de-prescribing. Now coming to one real life case, a 61-year lady who is diabetic, asthmatic. Today is World Asthma Day. So hypertensive, coronary artery disease, suffering from coronary artery disease, dyslipidemia, persisting peripheral edema for 6 years, low back pain for 3 months after fall in bathroom. There is atrial fibrillation 4 years back, asthma exacerbation multiple times, emergency room visit for that. Anemia is there, knee replacement done 3 years back. And the thing is that she is metformin intolerant. And for this lady, if as we take a detailed medication list, we found these all medications were taken by this lady. Among this prescription, naproxen, furosemide, extra dose of furosemide, and another thing is missed, that is prednisolone. The patient is taking frequently prednisolone. And you can see here, the naproxen was prescribed by some orthopedic doctor due to when she felt in the bathroom and have a low back pain. And that time for a short duration, 5 days, she was prescribed with naproxen. But as that particular medicine help her to have a improved quality of life by reducing pain, she is continuing it. So now if we just consider the history, the purpose of her visit, that is number one, the increasing exacerbation of asthma. And that is why she is taking prednisolone regularly. And another cause is the heart blood glucose, which was almost stable. HbA1c was 7% 1 month back, but for last 1 month, it was between 300 to 400. Increase the frequency of salbutamol MTI. And now if we go by detailed history, then we will find that due to some financial constraint, she was unable to purchase the fluticasone containing fluticasone plus salmeterol fixed dose combination. And obviously, she has pedal swelling for long duration. And for that, he was taking extra doses of furosemide. Now, considering these problems, if you just check again her medication release, then we can find where we should do de-prescribing to optimize her care. Number one, while we are prescribing naproxen, it is our duty to educate our patient regarding the danger of chronic use of naproxen. And if you can consider this patient who is suffering from anemia, then diabetes, pedal swelling, so most probably some underlying renal compromisedness is there. So on top of that, if I am taking naproxen, so what happened? My renal parameters will be deteriorated. And there will be more water retention, more swelling. So it will act like a cascade, a cycle, a vicious cycle. So we need to address that. Along with that, as we are seeing the patient is suffering from chronic pedal edema, and the patient is on pioglitazone, we know that metformin could not be used in this setting as she was totally intolerant. So pioglitazone, it is better not to use in this patient, in this scenario. It should be de-prescribed. Coming to the dose of atorvastatin. So in a background of ischemic heart disease, in a background of diabetes, is this dose is perfect? Is this 10 milligram dose is perfect? No. Generally, moderate to higher intensity statin is required in high-risk diabetes patient. Rather, you can see the patient is taking some beta blocker, not taking any beta blocker, okay, in context of ischemic heart disease. Whether it is actually required or not, that is a issue, that is a domain of cardiologists. But that is again a very important decision we need to make. Along with that, if I am using diltiazem with lanoxin, so we know the diltiazem and lanoxin has an adverse drug interactions which increase the concentration of the lanoxin, that means digoxin, and increase the toxicity, digoxin toxicity. So how much it is rational to use non-DHP CCB in this case? Whether it, as we are seeing this patient having some edema, some anemia in background of diabetes, whether it is there is some underlying diabetic nephropathy is persisting or not, we need to check. And whether even if it is not there, the patient is suffering from had a history of ischemic heart disease. So the role of ACE or ACE inhibitor or ARB is very important here. So instead of having diltiazem, whether it is better to prescribe one drug which provides some renal benefit and provides some cardiovascular benefit, that means AC or AC inhibitor or ARB. That is very important to decide. And it is our duty to check, to monitor. Yes, the patient is taking potassium chloride for prolonged duration, 20 milliequivalent per daily. But whether the potassium is okay or not, that is very important. That monitoring is very important. And as the same patient, due to pedal swelling, she is taking frequently extra dose of furosemide 40 milligram to reduce swelling, to have some improved quality of life. So that is also very important issue to address, because extra dose of furosemide, that means there is more chance of hypokalemia, more chance of digoxin toxicity in background where patient is already taking diltiazem, which reduce the metabolism of digoxin. So these all issues need to be taken care of by that principles of clinical pharmacology, clinical pharmacological reconciliation, review, and feedback of drug therapy. And another important aspect which we had missed, that is, patient was having some financial issues. And for that, she is not buying medicine, cannot buy medicines like fluticasone, salmeterol. And for that, she need to take steroids because it is cheap. For that reason, maybe she is stop taking insulin, because you can see the lispromix is quite expensive. So in this case, whether if we need to assess, we need to ask patient in a non-judgmental way whether there is some existing financial problem is present, and according to that we can change the treatment regimen. So that is very important. I think these issues need to be addressed. In case of asthma, we know the budesonide and formoterol combining drugs are much cheaper. So we can go for that. And in case of insulin, we can choose human mixed-stirred insulin. It is much cheaper than the lispromix. So these all issues is very much required while we are applying the principles of de-prescribing. So first point of de-prescribing is that a certain all drugs the patient is currently taking and the reasons for each one. So all drugs means all drug, including the non-prescription medicines, because in this case only you can find, if we just check the prescription drug, will not find the naproxen, will not find extra doses of furosemide, we will not find the prednisolone dose she is taking. So this is why detailed medication history is very important. And it is important to ask the caregivers too, because patients sometimes cannot tell us. So detailed history, detailed medication history from caregivers is very important. And sometimes it is very important to ask them to bring all drugs and even the drug delivery aids to consultation. Particularly in this patient, the asthma is not controlled. Whether the patient is taking inhalational drug in a correct way, that requires a good inquiry. And for that, we need to help our patient, to aid our patients to improve their inhalational technique too. And ask patients in a non-judgmental way about any regularly prescribed drugs not being taken, and if so, why not? Either it could be too expensive or some adverse effects. Like in this case, what happened? The patient, if we just check the prescription, we'll see, okay, the patient is taking a salmeterol and fluticasone combination, a fixed dose combination FDC. But actually, she is not taking that due to price. So if we not take proper history, we'll miss it. Next point, consider overall risk of different drug-induced harm. There are factors like number one factor is the number of drugs. If number of drugs increased, then the drug-induced harms will be more. The chance or risk of drug-induced harm will be more. Use of high-risk drugs. If a patient is taking some anticoagulants, some NSAIDs, some drugs like digoxin, which has a narrow therapeutic range, or some hypoglycemic agents, some drugs which are having anticholinergic effects. So we need to be very cautious then. We need to understand whether that drug could be de-prescribed or not, or as that drug need to continue, so whether we can de-prescribe other drugs. So in this case, the de-prescribing diltiazem may be required. To continue digoxin, we may need to require de-prescribing diltiazem, and instead of diltiazem, we can bring some ACI or ARB. Whether there is a past or current history of toxicity. Here we can see the patient taking repeated dose of naproxen and having some pedal swelling. So we need to educate our patient. This is due to your naproxen. You need to stop it. Don't take it in future. And there are some other patient-related factors which also increase the risk of drug-induced harm, and we need to be very much vigilant and need to give stress on de-prescribing intervention if the patient's age is more than 8 years, if there is cognitive impairment, there is multiple comorbidities, some substance abuse history, multiple prescribers involved. So again, that is a very high risk zone. As already we had discussed previously, a patient is going to visit one orthopedic surgeon, one ENT surgeon, one medicine people, one gastroenterologist, one endocrinologist, and finally he will be puzzled. So there should be one doctor, one physician who can help the patient with this concept of clinical pharmacological review, reconciliation, and feedback. Past or current non-adherence history. There you should be more focused. Finally, we need to assess each drug for its eligibility to be discontinued, whether there is no valid indication for particular drug. Part of a prescribing cascade. So in that case, in the we had discussed about naproxen. It is a part of prescribing cascade. So naproxen causing some renal injury, which leads to pedal swelling. And for pedal swelling, the patient is taking again furosemide. So ultimately, this cascade is going on and on. So we need to understand who is responsible for this prescribing cascade, and we need to de-prescribe that. Actual or potential harm of a drug clearly outweighs any potential benefit. Disease and or symptom control, drug is ineffective or symptoms have completely resolved. So we need not to continue that particular drug. Preventive drug is unlikely to confer any patient important benefit over the patient's remaining lifespan. If a patient is suffering from pancreatic cancer, she is going to live for 6 months maximum. So now, if I am prescribing a statin to that particular lady, as she is also suffering from diabetes, so is it right? We need to de-prescribe that. And drugs are imposing unacceptable treatment burden. So there we need de-prescribing. So these are important factors, and we need to be very vigilant while doing this de-prescribing process. And if we find any points from here, then we need to do that de-prescribing. And for that, there is another important scale, anticholinergic burden scale. That means there are some drugs which is not actually anticholinergic, but they have some inherent property of being anticholinergic. You can see in the ACV score 3 list, there is one drug known as paroxetine. We know it is a SSRI. Now, if a patient is taking paroxetine, so there is already 3 score of anticholinergic burden. So it has some inherent property of anticholinergism. So it aggravates anticholinergic side effects. And one of the major reasons of this anticholinergic burden is taking more drugs which has anticholinergic inherent properties. Like a patient is taking one this paroxetine, again the same patient is taking digoxin or furosemide, which has 1 score, low score, but it is 1, 1. So 1 + 1 now +3, so it becomes 5. So any score more than 3 means there will be more cognitive dysfunction. So in case of elderly population, it is very important to check the anticholinergic burden, and we should try to de-prescribe those drugs, this prioritization is very important for discontinuation, that which drug is going to harm me more. So those with greatest harm and least benefit should be de-prescribed. There are some drugs which is very easier to discontinue because of their lowest likelihood of withdrawal reactions or disease reboundness. And sometimes the patient himself will say, I want to discontinue this particular drug first. So that will also help us to decide or to prioritize drugs for discontinuation. But as we had previously discussed, after discontinuation, after de-prescribing, we need to monitor, because there could be a possibility of harms like withdrawal reactions or return of disease. So we need to stop one drug at a time so that harms and benefits can be attributed to specific drugs, and that could be rectified. Wean patients off drugs more likely to cause adverse withdrawal effects. So we need to instruct patients or sometimes caregiver on what to look. So what are the red flag signs, and to report to us if such effects happen, and fully document the reason for outcomes of the de-prescribing. The documentation is also very important because it is going to be, it has a potential to become a medical legal document too. So we need to be very cautious. So this is the algorithm for deciding the order and mode of de-prescribing. This is the summary slide. First of all, we need to check whether there is no benefit for particular drug, there is some significant toxicity or no indication, or obvious some contraindication is there, or part of prescribing cascade. If it is yes, then we need to check whether after discontinuing particular drug, there is a possibility of withdrawal symptoms. If it is yes, like in case of prednisolone, the patient is taking prednisolone prolonged. So in this case, so we need to taper the dose, and then we can withdraw the drug or de-prescribe the drug. Next point is harm outweigh benefit. So whether the adverse effect outweigh the symptomatic effect or potential future benefits. So that need to be taken care of. Next point is symptoms or disease. So symptoms is stable and disease is non-existent. So if it is yes, then we can withdraw the drug. But again, we need to monitor for any withdrawal symptoms or the disease is coming back or not. If it is not, then we can discontinue the drug. Next is the preventive drug. So if there is some potential benefit is not likely to be realized because of that reduced or compromised life expectancy, then also we need to withdraw that particular drug. So this is in nutshell what is about de-prescribing, and in this cartoon you can find that story why de-prescribing is required. This is the very common story of prescribing cascade. That means patient is having some drugs, maybe 3 or 4 or 5 drugs, and patient having some symptoms. And that symptoms is actually due to one of those 5 drugs. But without withdrawing or de-prescribing that particular drug, we are adding some other drug to reduce those symptoms. And what happened? That another drug is going to create some other adverse effects. So again, without de-prescribing that second added drug, we are adding some another drug which is actually going to produce another symptoms. So this adverse effect is going on. And finally, what happened? We are using one drug which ultimately producing symptoms like my index symptoms, the first time symptoms. So if I am just having a hypertension, so actually that particular drug, when we add 4 times or 5 times later, fourth or fifth in sequence, that again causing hypertension, rise in blood pressure. So that cycle is known as prescribing cascade, and this prescribing cascade need to be prevented by de-prescribing. But one thing we all should remember while doing this de-prescribing practice, this mantra should be there. That is, no blame, no name, no shame. De-prescribing process, if we have practiced this thing, blaming, naming, shaming, so this will be very much unfortunate, and that this will kill the very essence of de-prescribing. So we need to be very clear about that. Thank you very much for your patient hearing. I am just sharing one case with all of you. I want your comment on de-prescribing in this particular case in the chat box. We can address that issues later. So a 68-year male who is suffering from hypertension, ischemic heart disease, COPD, having persistent hyperuricemia of 10.2 milligram per DL. Now medications ongoing, a fixed dose combination of telmisartan, amlodipine, chlorthalidone twice daily, diltiazem 90 milligram once daily, atorvastatin 20 milligram, clopidogrel 75 milligram, febuxostat 80 milligram. In spite of taking febuxostat 80 milligram, you can see the uric acid 10.2. Fixed dose combination of salmeterol, fluticasone, salbutamol, epratropium, alprazolam 0.5, and finally, from detailed history, it was found he is taking also omeprazole 20 milligram as an OTC drug. So now there are multiple areas where the patient requires de-prescribing. So your comment is most welcome. You can put your comment in the chat box and we can address those answers in the chat box later. So once again, I want to thank you all for your patience hearing. Thank you very much.